Hello, today we're going to talk about return OB visits, and along with that, I'd also like to talk a little bit about models of prenatal care other than our standard routine prenatal care, and touch a little bit on preparation for childbirth and how we help our patients do that. I'm not going to spend a ton of time on that. I really am going to focus mainly on the return OB visits. So looking at our objectives for the lecture, we'll do an overview of the interval OB visits or the return OB visits. We'll go into a more detailed look at that. We'll look at group prenatal care, of which centering has probably been the most researched group prenatal care, and then just touch lightly on preparing for childbirth and how we help our patients do that. So the overview, at each visit, when they come back to us, we continue to, if we kind of break it into subjective, objective, and teaching, we start by continuing to really work at building that trusting relationship. And a lot of kind of how we gather our subjective data, I think, happens organically by just asking the woman and her partner, so what's been going on? What questions do you have? Or have anything happened that you're concerned about? I think just kind of opening it up that way, we gain a plethora of information. It's amazing. I mean, people are very invested in their pregnancy, so they will tell us a lot. So just by asking them that, they usually come in with a very long list of questions that they have. So all we have to do is really open up by, hey, what questions do you have this week? Or this month, depending on where they're at. So we'll gather a lot of subjective data just by that. Really pay attention when they are talking about where she's at with her eye contact. What is her tone of voice? How is she interacting with her partner? Some partners come to a lot of the visits. Some aren't able to because of work, so that doesn't always give you a ton of information. But if he or she is there, watch how they're interacting. We'll talk a little bit about this more, but that's an important thing to be watching and monitoring when you can. Another thing we do want to ask about, and this is subjective, is the fetal movement. Most fetal movement starts between 18 and 20 weeks. I usually start asking around 16 just to have them start thinking about that. So if they don't start feeling it sometimes they don't start feeling it until 20 or even 22 weeks, especially if they have an anterior placenta, and that is okay. Because that anterior placenta can kind of act like a big pillow or a cushion, so it's really difficult for them to feel it. So to reassure them that that's all right. But do start asking if they are feeling any flutters or feelings of like gas bubbles or anything like that. So we do start asking around that time. Objective assessments, we're always checking weight and blood pressure at every visit. We're also doing urine testing, usually though not at every visit unless it's indicated. So the things that would indicate it would be any signs of a UTI, any concerns about possible signs and symptoms of preeclampsia, maybe diabetes if we're worried about she's spilling any glucose into her urine. So usually we only test out the initial visit, then again at 36 weeks. The other objective pieces that we'll start measuring fundal height in centimeters at around 24 weeks. I personally like to also check at 20 weeks because at 20 weeks the fundal height should be at the umbilicus. That's just my practice. Other providers may be different. And then we also listen to fetal heart tones. Typically, you should be able to hear a fetal heart rate with the Doppler at 12 weeks, depending on maternal how thin she is. Sometimes that can be a little bit difficult. The fetoscope is usually between 16 and 20 weeks. So, and that is very provider specific. I am terrible at it. Just full honesty there. I have a very hard time finding it. So that's something that is a skill that you definitely get better at. So fetal heart rate assessment, though, is something that we do listen to at every visit. Teachings, we want to do teaching signs, and this is somewhat visit specific. So we're always teaching about danger signs and when they should be calling or going to the hospital. We do start teaching about fetal movement counts. We'll talk a little bit more about this at a different lecture, but usually between 26 and 28 weeks we start talking about that. We talk about normal discomforts of pregnancy, so what's normal and what's something that they should be concerned about. And then we'll talk about preparing for childbirth, the different components of that we'll want them to be thinking about, like bringing the baby home, different like feeding methods, things they want to be thinking about as they're getting ready. So that's kind of the overview, and I've whipped through this slide very quickly, but a lot of this is in your textbooks and in the readings that you have. So now, more detailed. Hang on, ladies, here we go. So, history. So looking at the subjective pieces, if nothing, like I said, a lot of it does kind of come up organically as we're asking them questions or as they're asking us questions. It is amazing how much of this will just kind of come up through our talking. But what we really want to make sure that we're touching on when we're talking about what's gone on since we've seen them last, these are the pieces that we want to make sure. So we will, like I said, we want to make sure that if they have felt fetal movement, we want to make sure that that they are continuing to feel fetal movement. We also want to make sure that we always ask about any like vaginal discharge, any leaking of fluid, or vaginal bleeding. And we want to make sure that we're asking about any contractions or cramping and then document that. So kind of an obstetric review of systems. So, and you always document that. She denies leaking of fluid, she denies any leaking of fluid or vaginal bleeding, any unusual discharge, denies cramping or contractions, especially in that preterm period of time. And then always that she displays appropriate, or she states appropriate fetal movement. So you're always documenting that in your note. The other thing is that we want to talk about her medical history. So has she had any problems? So has she had any signs and symptoms of a UTI? Has she had any respiratory issues like, seasonal allergies or cold, any flu symptoms, anything like that? Has she had to go to the ER for any reason? It's amazing how many times that happens. So make sure that we ask her if she's had any problems. And then if she has any chronic history in her chart, thyroid problems, asthma, migraines, etc., we want to make sure that we review the status of that and see if she's had any issues. Social history, so always just wanting to make sure that she's doing okay. If she has a job that requires her to stand a lot, how is she doing with that? Is she able to get her breaks? Is that causing any problems with the pregnancy, like cramping? Just checking in with that. Things going okay at home? Does she feel like she has good support? Are they able to start doing the things they need to prepare for the baby, etc.? Does she have the resources that she needs? Do we need to get her in contact with WIC? Do we need to help get her in like a baby prep class where they can learn how to prep for, like how to learn how to change a diaper, or just all over like baby care classes? So kind of just starting to assess for their like knowledge base or her support issues or whatever that she has at home, and kind of circle around and help her in maybe where she needs the best support as they get ready for that. The other thing is to always try and assess, especially in this day and age, any alternative therapies or essential oils that she might be using, over-the-counter medications. I always, in the initial OB visit, really try to hit home that just because it's over-the-counter doesn't mean it's safe. And just because it's an alternative or an essential oil also doesn't mean it's safe in pregnancy. Because not everything is safe in pregnancy, even though it's, healing, healthy, alternative. Even massages need to be done really carefully because it can trigger contractions. And so really wanting to make sure that we're educating around that. And so I ask my patients all the time, like, hey, what new things are you trying, or what are you doing? And just documenting what they're using. So for our physical exam in these return OB visits, Again, we're doing that blood pressure and we're weight, and we're comparing that to the visit or their last visit. Monitoring that weight gain to make sure that they're not gaining too little or too much, and having conversations around that, hopefully not having to do too much of that. Again, only a UA only if indicated. We're looking at proteins, specific gravity for dehydration, leukocytes if indicated for potentially UTI. We're doing an abdominal exam, fundal height, usually at 20 weeks, like I mentioned before, and then measuring in centimeters at 24 weeks. So what we want them to measure in centimeters what they are in weeks. So at 24 centimeters, I want her to measure at 24 weeks, I want her to measure 24 centimeters, plus or minus 2. So she measures at the 24 weeks, so she measured 22 centimeters, that would be just fine, all the way up to 26 centimeters. If she measures greater or less than that, I usually feel like I'm okay if she has 2 off measurements, because baby can pee out or swallow amniotic fluid. But if she measures more than that 2 times in a row, then I'm sending her for an ultrasound to be evaluated. So that's how I do my measurements. That's my rule of thumb. Some people are a little bit more than that. If it's off 1 centimeter 2 times in a row, they'll send it. I haven't found anything that supports one way or the other, but so that's how my rule of thumb is. So 2 centimeter off, within 2 centimeters is usually what we go by. So in centimeters, she should be in centimeters what she is in weeks. So at 28 weeks, she should be 28 centimeters, so on and so forth, plus or minus 2 centimeters. But if she has consistently off, then she needs to be sent for ultrasound evaluation. We also are measuring fetal heart tones. And then at 36 weeks, we are consistently doing Leopolds. We usually start doing Leopolds around 34 to 36 weeks for presentation. And if we are unsure what her presentation is, we would, at 36 weeks, we would be sending her for an ultrasound evaluation, because we would be considering doing aversion so that she can have a vaginal delivery. At a pelvic exam, we usually start doing those at 36 weeks and then weekly if the patient desires. We usually do them at 36 weeks just to see what her cervical status is. After that, it really is only if the patient desires. And why is that? Well, it's nice to have a baseline at 36 weeks so we can see how favorable or unfavorable her cervix is. But it really doesn't make that much of a hill of beans difference when she comes in labor, because we're going to assess her labor status at that point in time. It's nice to say, oh, you were 2 in the clinic and now you're 6. Great, you've made huge change, but it doesn't really matter if she's 4 when she comes in. We're still going to keep her and see if she makes change in 2 hours or not. We're not going to necessarily change our management that differently. We're still going to keep her and watch her for 2 hours before we'd make any change. We're not going to, if she came in at 4, we're still going to monitor her for 2 hours. We're not going to make our management plan based on what she was in the clinic. I hope that makes sense. So her clinic cervical status doesn't change what our inpatient or our birth center status is. We really are only looking at that point in time in labor, if that makes sense. So it helps. I think for the patients, they kind of like, some patients really like knowing, but for patients who maybe have a history of abuse or where cervical exams are difficult, it doesn't matter that much, so we shouldn't put a ton of emphasis on it for them. So it's it really is an empowering thing for them, that they should be able to make that decision for themselves one way or the other, because on our end it doesn't have that much meaningful data, so to really let them have that choice for what's most important for them. The health screenings that we do in these return OB visits are 3. So we really need to do intimate partner screening for violence at least once a trimester. We know that women who are in violent relationships, the risk of it increasing in violence is incredibly high. If they started out with just a little bit of it, once they become pregnant, they're even more vulnerable to exceedingly more violence because the partner knows that now he has them. Now that they're pregnant, that they're so, quote unquote, stuck with him forever. So the risk of the violence becoming even more violent is very, very high. So we want to screen for them at least once a trimester. We know that intimate partner violence leads to the outcomes that I've led here: poor weight gain during pregnancy, anemia, smoking, all types of infections, abruption, fetal injury in stillbirth. I should have a comma there, and low birth weight. Sorry for that typo. Studies show that we can use both either face-to-face or computer questionnaires because either one are just as effective. So it doesn't actually have to be us asking them. So if your clinic has a computerized questionnaire, that would be great. We know that a woman has to be asked, the studies show, anywhere from 3 to 7 times before they'll actually admit to being abused. So the more that we can kind of get this in front of them and have them being asked, the more likely we are that they'll actually admit to them, and we can get them the help that they need. And on the next slide, I actually have the resources for intimate partner violence that you can use. I think it's also in some of your textbooks and readings from this week. So really, really important that we're monitoring for it. And they are often asked as well when they're admitted into the hospital, but sometimes it can be really challenging because their partners are there with them. So the more that we can do this, the better. We also need to screen for depression, and ACOG wants us to screen. The recommendation is once during the pregnancy and also at the postpartum visit. Postpartum depression is something that I feel very passionate about, and you will be learning quite a bit about that in your 617 course. So we're not going to talk about it a ton, but you do need to use a validated tool. A lot of people will use the Edinburgh Depression Questionnaire or the PHQ-90. So either one is fine. Just make sure that you document your results and what you have, what your results were. And then also drugs and alcohol if appropriate. Like I mentioned in another, in your first OB lecture, it's amazing how many women are now, especially with the legalization of marijuana, are using marijuana as a nausea prevention. So if you know that they did that, it's really important to circle back at least once to make sure that they aren't still using marijuana. You don't necessarily have to do a drug screen on them, but at least circling back to ask about it. And if you are suspicious that they are, it might be worth doing a randomized urine tox screen on them. And again, just asking about those drugs and alcohol if you know about it. So here are the resources. There's lots and lots out there. So that's in your notes, and then also, like I said, in many of your resources listed for this week. Laboratory assessments. So there's several, and there's the 16 to 20 week lab assessments. We're going to talk more about this in some future lectures or past lectures. We do the neural tube defect or the triple or quad screen at between 16 and 20 weeks. If they did the non-invasive prenatal test, oftentimes instead of doing the quad screen, they'll only do the triple screen because so much of that was captured in that NIPT. And then between 24 and 28 weeks, we'll screen for gestational diabetes and then also do another CBC, usually for your hemoglobin and hematocrit. And then also, which I don't have listed here, and then we also do an antibody screen if they're Rh negative and give them their RhoGAM shot. And then at 35 to 37 weeks, we do a Group B strep screen culture and repeat any STI screening if indicated. So let's talk a little bit more about the Rh-LO immunization prevention. So just as a review, there's 2 types of incompatibilities. You have your ABO incompatibility, which is when you have a type O mom who has a baby with a type A or B blood. And this is this isn't very scary, less severe than your Rh incompatibility. And we typically don't do anything to treat this because there's not very many proteins on the red blood cells, and so the antibodies don't attach to the red blood cells in enough numbers to cause harm, so we don't see damage to those red blood cells like we do in the Rh incompatibility, and that's when you have an Rh negative mom with an Rh positive baby. And this, you do get sensitization, and antibodies form and attack the red blood cells, and you have increasing risk with each subsequent pregnancy with a baby that has that Rh positive blood. And so the treatment is typing the blood of the baby using their cord blood to find out if they have positive blood, and if they do, you give mom the Rogram at 28 weeks, and then you would give it to her if the baby is Rh positive at delivery time. And that is how you prevent those antibodies from forming and then attacking subsequent babies. So the initial baby is typically safe because that's when those antibodies would form. It's subsequent pregnancies that become more and more at risk for this. So that is why we give the Rogram. I hope that all makes sense, and this is more of a review for you than anything else. And now GBS is the other thing that we do at 36 weeks. And I always find this so fascinating. This is a gram-positive coccus, but what I find fascinating about this is a normal organism in everybody's GI tract and in the genital tract of women. And it's colonized in 15 to 40% of women. And I find that this is not research-based, this is just completely my experience, that it seems to be in a lot of nurses are colonized. This is just a little aside of my experience. But typically women are asymptomatic, so they don't know when they're colonized or not. And so they can go their whole lives and have, their body will colonize and then take care of it and colonize and take care of it and never know. So because of that, in my career, we've gone through several different protocols of when to culture, when to treat, when not to culture, when not to treat. So right now, the recommendation and protocol that we've landed on is to screen between 35 and 37 weeks, all women, and treat during labor if positive. Additionally, if the GBS was found on the urine culture in the initial OB visit, that indicates a very, very heavy colonization. And so we should treat them at that point and then again in labor, and we don't need to rescreen them at 36 weeks. So that's the protocol, and I'm not going to go through the antibiotics right now because you can look that up, and it's on every admit sheet that you'll ever know, and someone's going to get the lovely job of going through this PowerPoint lecture in your 617 course. So I'm going to let that go for right now. But this is the protocol, and the reason that we do this is that although it doesn't affect or impact women who have it, it's very, very dangerous to babies. And there's a percentage of babies who will get incredibly sick if they're born to women. Not every baby that's born to a colonized woman will get sick, but there's a percentage of babies that will get very sick with GBS. And of those percentage of babies who get sick with it, there's another percentage of baby who will die from it. And when they did their analysis, they found that just from even, how heart-wrenching it is, it's terrible, and why not try and save everybody? Even just from a cost perspective, it makes sense just to, not only try to save everybody, but even just makes sense from a cost perspective to just screen everyone and treat everyone. It just made sense. So this is where we've landed. And believe it or not, women can actually self-collect from this, though in my practice, we've never done that, and I've always wondered why not. But it can be self-collected. And so it doesn't have to be with a speculum, and we never have done it with a speculum. And it only has to go into the external third of the vagina. It's a Q-tip swab. And then, so they swirl it into the third of the vagina and then insert it into the anus just to make sure that they get a large enough inoculation, because remember, it comes from the GI and the vagina. So vagina first, then into the anus, and then you're done. So that's how you collect the GBS. And hopefully you all have had an opportunity or will have an opportunity to collect that sometime this semester. And then ultrasounds are another part that get done. So usually at between 18 and 20 weeks. And I know that our ultrasound techs like to get as close to 20 weeks as possible, just to get as much of this anatomy that they can see as possible. Sometimes at 18 weeks it's a little hard to see everything. But they do a fetal anatomy survey. And then sometimes at 36 weeks or more, we'll check for fetal position, and then occasionally for antenatal testing for a variety of different indications. So that is all the Return OB visits in a nutshell. So moving on to group prenatal care, I'm not going to go into this a ton. This is centering pregnancy is probably the most researched model of group prenatal care. Several of the previous Bethel grads have done their capstones on this. If you would like to pull that out and read it, they're fascinating and really well done, and can give you a lot of excellent information on it. But in a nutshell, group prenatal care is when groups of 8 to 12 women or couples are put together at around the same gestational age, and they will meet together between, well, it says 12 to 16 weeks here, but I think it can start as early as 10, and they meet in large group sessions, and there's usually a topic that they will be discussing, and often it's run by a nurse, and the topic, like at 12 weeks, may be like maybe it'll be the non-invasive testing. And while they're talking about it, the women will all come in and they'll go weigh themselves and record their weight in their charts. And while they're talking about that, one by one, they will go in and meet with the nurse midwife or the provider, and they'll listen to heart tones, and they'll have their fundus measured if that's the gestational age they're at or whatever. And have their blood pressure monitored and maybe ask specific questions. But then they'll have this big group time together that's about a 90-minute session. And then that's it. And they have their questions answered together as a big group. They ask questions about the pregnancy. And a lot of times what they have found is that the women who have had babies before can answer questions to the women who haven't had babies before. And they have this kind of environment that's really empowering to one another, because they walk alongside each other throughout this whole time together. And the research around it has been a little bit mixed. It's as effective as far as outcomes have gone. Like, it's not better or worse necessarily than traditional prenatal care. It's definitely self-empowering. But what has come out very strongly is that for groups that are at risk, like teens, or groups that have disparities in them, whether it be economic or racial or social, those groups really benefit from this model of care. And probably because those groups tend to live on the fringes of our society, that we can pull them together and empower them and really pour into them education, and pour into them this this self-empowerment. I think that's why they benefit so much from this model of care. So I really encourage you, there's quite a few resources that are in Moodle, and some resources to read about. I really encourage you to delve into it. I think there's also a website to go to. I hope that some of your sites I know do this model of care. I hope that you get an opportunity to see it. It's been really, really fascinating to watch it grow over the last 10 years. And I know it's been around much longer than that, but it has become much more popular here in Minnesota, at least for the last 10 or 15 years. So hopefully y'all get to see it. And I have here, this is from Oregon. They just put this up on their website and I copied it here. But just an idea of kind of how they do their visit plans. So they kind of have a blended model where they do individuals and groups. So they get a little bit of both. So they have 5 group sessions, and then the rest are individual. And you can see they also meet as a postpartum group. And there's been, in some of the research that I've read, that some of these women are meeting together even like 5 and 6 years post-delivery. Like they have really bonded and really support each other. And that's really where, especially in this postpartum period, it has really helped with like postpartum depression and some of those pieces. So that's group prenatal care. And then the last thing I want to talk about is the preparation for childbirth. And I'm going to tell you that I could probably spend 3 or 4 lectures talking about preparation for childbirth. And I'm not going to do that because there's so much here. There's quite a bit in your slide, or in your readings, excuse me. One thing I do want to just pause and talk about a little bit there's an article that I posted about birth plans, trip to the OR, and I realize that might sound a little bit snarky, and I don't want it to come across that way at all. And I'm just going to share with you my heart here. So here's my heart on this. I've seen a lot of deliveries in my career, and I truly, truly believe that God gives women the birth that they need, which is not always the birth that they want, but it's the birth that they need. And that is amazing to see. And so I think as midwives, if we can help our patients to frame their birth as something that's going to give them the strength and the courage in a lot of ways to let go of the pieces in their past so that they can embrace the parenting that's in their future. That is sometimes what I feel like birth is. And sometimes I feel like birth plans become a barrier to that because it's more about controlling out of fear than it is embracing out of openness, if that makes sense. And it's when women have, they're coming at birth with so much fear and they want to control is when I see things go poorly. And that's really where our trusting relationship that we have built through our prenatal care can really come into play, where we can say, do you trust me? Like, do you trust what we've built? And can we talk about this birth plan and tell me what you're fearful of? And let's talk about this. And so if you can help women by bringing that birth plan in like at 36 weeks or earlier and talk with them, the worst thing is when you're handed a birth plan in the middle of labor. And by then it's kind of too late. So really trying to get that birth plan beforehand. Control is, I work on my control issues. I struggle with that now. I mean, it's something, we all have things that we are fearful of, and that's when we most want to grab onto it and control. So I'm by far perfect from this, and I have my own, we all have our own things, me included. But that's, I guess, in birth when I feel like if we can help women see what they're scared of with it, and we can help them by giving them knowledge, or help them by lessening their fear or making them feel safe or empowering them where they need to be empowered, that's where I feel like they're going to have the best birth that they need. So that's my heart with birth plans. They're not necessarily in and of themselves bad, but they can become bad when they're used to control. Because rarely does birth go like anyone dreams it's going to go. I mean, in fact, I don't think it ever does. My other analogy for birth that I tell patients often is that births are kind of like a wedding. Like, never does a wedding go exactly like it's going to plan. Something always goes wrong. It always does. I haven't gone to a wedding yet where it ever went perfectly without a hitch. Yet, there's not a bride and groom out there that will tell you 5 years later. I mean, the wedding has zero to do with your day-to-day marriage. Nothing. It has nothing to do with being married day to day. So the birth, although really important and beautiful and wonderful and amazing, just like the wedding, really important, beautiful, wonderful, amazing, the birth has zero impact on how you parent day to day. It has nothing really, I shouldn't say nothing, but has very little, if any, to do with how you parent. It's important, but it's not the end-all be-all. So if you can kind of walk into it with this idea of, I want it to be special and I want it to be amazing, and we all do, but just kind of know that it's not going to go how you expect, and kind of just expect to roll with the punches. That's when beautiful birth happens. And know that God will give you the birth you need to let go of the things you need to let go of so you can embrace the parenting that's facing you. I think that's kind of a great gift to give your patients. So that's my spiel. I hope that's not too much on labor and birth expectations, but that's my spiel for whatever that's worth. We'll talk about childbirth education classes on the next slide. Newborn procedures are another thing that we start talking to our patients about, and I really encourage them to pick out a pediatrician and meet with them prior to the birth, if at all possible, and then talk to them through this. Things like circumcisions is a kind of a hot button topic, and insurance kind of drives a lot of that. Some insurances will not pay for it in the hospital, some insurances will, so they'll want to think about that. Breast versus bottle feeding is another big thing we want to make sure we're talking to them about. And then preparing the home for the newborn, like the nursery. Are they sleeping in the bed, sleeping in a crib? Are they co-sleeping? Like those kind of pieces that we'll want to think about. And then usually around that 34, 36 week visit, I usually start having them think about postpartum contraception and what they are thinking about that, and that breastfeeding is not an adequate method of contraception, so that when they are at the hospital, they have a good idea of what they want for those pieces. So models of childbirth education, we have your good old famous Lamaze, which was your good focus on breathing and relaxation techniques. We have Bradley method, which we have the partner coach childbirth, very popular method. This focuses on exercises and slow, controlled abdominal breathing. Dick Reed, which is kind of the founder of natural childbirth, focuses on knowledge and ways to reduce fear and breathing. He focuses on knowledge as a way to reduce fear and using breathing techniques. Hypnobirthing, which you probably have all heard of, using deep relaxation to break the fear, tension, and pain cycle. Mindfulness-based childbirth prep, using meditation and yoga to reduce stress and increase awareness. Incorporates the partner as well. Birthing from within is a newer method, which I am not as familiar with, but they believe in preparing the heart and soul as well as the mind and body using art, ritual, storytelling, visualizations, ceremony, and community. They're very focused on avoiding birth trauma. They have a wonderful website that I would encourage you to explore. Hospital-based classes are very kind of focused more on the whatever the theory of that particular hospital or provider's group is. And nowadays there are all kinds of online childbirth education classes that will really can suit the needs of your patients. So if you have patients who are very busy, there's all kinds of online resources that they can use as well. My particular bias is that I would rather just have my patients prepared. I just want them to have knowledge. I just feel so badly when I have a young gal who has no knowledge whatsoever. I would rather just, I want her to have something. So I encourage her to just find something. I don't care what method you use. I just want you to have something that empowers you so that, any knowledge is better than none. So I usually hand a variety of resources, including online, and just encourage her to do something. So those are the different opportunities and options that she has. And your sites will probably have something that they recommend as well. And these are my references, and that is all. If you have any questions, please post them in the forum. I hope you all have a wonderful day, and like I said, please email or post something in the general forum if you have any questions. Thanks so much.